My name is Stephen Angelette. I'm a healthcare lawyer at Polsinelli here in Dallas. I serve on the board of the Chamber, and I'm the chair of the Healthcare Committee, as Ken mentioned. The Chamber hosts its annual healthcare conference in January every year. And last year, we were batting around ideas for expanding our healthcare programming. Luckily for us, around that time, Pat Driscoll, Kenya Woodruff, and Ben Isger from the Health Industry Council Foundation came to us with a proposal for a partnership. The Health Industry Council Foundation's been providing thought leadership in Dallas for over a decade, and we hosted our first program with them earlier this year. So we're excited to host another of our quarterly-ish programs with them today. One note, we've gotten really good at using the chat function to direct questions to the speakers as valuable sort of like alternative means of ongoing discussion. So please post questions or comments as they occur to you, we'll engage. We'll try to integrate those questions into the program. The moderator today for our health benefits discussions, Mr. Rob Causey. He's the managing director of the Dallas office of Higginbotham and Associates, a large Texas-based insurance brokerage firm. He's been with Higginbotham for 21 years, specializing in employee benefits business. We're also proud to have had Rob serve on the board of the Chamber for the past 17 years. So Rob, thank you very much, and take it away.
All right. Thank you, Stephen. Let me introduce our panelists today. First is Sharon McClure. Sharon is the Senior Vice President of Healthcare Delivery for Blue Cross and Blue Shield. She's responsible for Blue Cross and Blue Shield's provider networks. She is a proud graduate of Texas A&M University, the Fighting Aggies. Sorry, Sharon, we can't hear all the whoops in the audience today. Next is Trent Hadley. Trent is the Chief Financial Officer for Baylor Scott & White. His expertise is value-based contracting and population health management performance. Trent is a graduate of Samford University and holds a graduate degree from what he calls the real UT, University of Tampa. I like that, Trent.
Right.
All right. First of all, my background is 30 years of broker consulting, as Stephen had shared with you all. And when I started in the business, there are far more than 4 major network organizations. Standalone HMO plans were meeting great resistance in Texas. And since that time, a great deal has changed, and also a great deal has not. Today, we have a distinguished panel of healthcare experts to discuss the challenges that we are seeing today. Corporate America has gone through a great change as a result of COVID-19, and the challenges that businesses are seeing with respect to their health plans has been significant. We're going to hear from each of our panelists their initial thoughts, and then we're going to go in to our panel discussion. So let's begin with Sharon. Take it away, Sharon.
All right. Thank you, Rob. Thanks, North Dallas Chamber of Commerce, for hosting this event. This is fun for me to be on a panel with Trent from the Baylor Quality Alliance, because if you go back 90 years, the idea of health insurance started here with what's now Blue Cross and Blue Shield of Texas and Baylor. There was a program that was initiated at that time during the Great Depression for teachers who could pay 25 cents a month and get 30 days of healthcare coverage. Pretty good deal at the time, and that took off. Certainly a lot has changed since then. And one thing that's changed recently, and we're going to talk about this a lot, is this shift to value-based care. So let me explain what value-based care means to Blue Cross and kind of means to the industry. Right now, most of healthcare, at least private healthcare, is paid for on a fee-for-service basis. So it's like kind of going through a toll booth. The more you drive through, the more you pay, the more services you get, and the more the costs increase. And there's really very little incentive for quality and outcomes. And value-based care is changing that. It's changing those incentives, possibly paying providers differently. It's exchanging data so that we can be more collaborative in caring for populations. And I think now is a great time with this COVID-19 crisis to really accelerate that change. Now, at Blue Cross and Blue Shield of Texas, we were early adopters of value-based care. And not all of our programs, but most of our programs are centered around primary care, that relationship between patients and their primary care physician. We established our first patient-centered medical home 10 years ago, back in 2010. We introduced our first accountable care organization, or what you might hear as ACO, back in 2014. And then 2019 and 2020, we actually started investing more in primary care with this collaboration with this international company called Sanitas. We have 4 health centers that we've opened with Sanitas in Dallas, 6 in Houston. And this is just really the acceleration where we have invested in and tried to create these incentives around value-based care. And what's the benefit of value-based care? Well, our ACOs over time have saved over $168 million, and it keeps getting better every year as the physicians get better at practicing in this environment. And the things that are improved are patients get accessed at the right site of care. They don't overutilize the emergency room. They go to their primary care physician instead of going to the emergency room for their primary care, and they have more coordinated care. And how has COVID-19 accelerated that? Well, pre-COVID-19, we had a booming economy. We had a big war for talent. We had incentives for employers who finance most of the healthcare to just keep things as it is. We want to, unemployment's low. We're at a big competition for talent. And so there was very little incentive to change benefits so that it enabled and encouraged value-based care. This all obviously changed in February. Not only have we experienced a global pandemic, but we're experiencing an economic crisis. And one silver lining is that it's causing many stakeholders, including employers, to rethink their priorities. And so if value-based care is going to be successful, it's going to include, I'm going to call them the 4 Ps. 4 major stakeholders that have to play a role in enabling value-based care. The first is going to be payers, providers, plan sponsors, that's employers, and then patients, or what we otherwise think of as members. And so all 4 of those stakeholders are going to have to rethink their priorities. So what does it mean for payers? We have always, as our state's largest insurer, we've long wanted to invest more in value-based care. That means that we have to have innovative and affordable products. We need to have the information systems and ability to exchange data with our provider partners and plan sponsors. And this is the way that we can improve population health. So payers, I think that we're on board, and we definitely are incentivized to move to more value-based care programs. Now, providers have experience in this fee-for-service world where, the more services provided, the more their financial incentive. Well, they've rethought that with COVID-19. You had to see providers shift to telehealth, which isn't quite as financially rewarding as having people come in the office. But as these providers have closed their offices or have had to close their offices, they might have been more interested in having a more steady income. And so value-based care, I think, kind of requires some providers to take their risks as they've struggled with closing their offices. And I think they're a lot more motivated to do this. And you'll hear more from Trent about that. And so Baylor Quality Alliance is a great example of a motivated provider who's investing in value-based care. Plan sponsors, employers. So introducing cost control or enabling cost control and rewarding quality in plan design is important. We've seen, as unemployment has been low, we've seen these broad PPO networks, open access, high deductible plans. Those don't necessarily enable value-based care, like I think you even mentioned it before, HMO. HMO has kind of been a 4-letter word in Texas, but there are a lot of advantages that HMO plans can encourage. They can encourage a relationship with the primary care physician where a member has to select that primary care physician and go to and use that primary care physician as their quarterback for healthcare. It also enables alternative payments like capitation instead of just fee for service. And it can also, if you have that primary care relationship, it can improve the member experience. So employers now, as they're looking to save dollars on their healthcare expense, they might be more willing to look at different types of plan design that enable primary care. And then finally, you have your patients. So individuals, members, I think that as we've seen this pandemic grow, people who were less likely to enter into a primary care physician relationship might see that value. Maybe they wish they had a primary care physician to call to talk about their symptoms instead of going into an emergency room or urgent care center. I think we're seeing patients see the value of that primary care physician relationship, especially if they have chronic conditions. So in conclusion, all of us here have to consider whether you're a payer, a provider, a plan sponsor, or a patient, think about value-based care and how we can improve. A lot has changed in 90 years. A lot has changed in the past 9 months. What hasn't changed is our commitment to our customers and our members. I think value-based care is essential to improving our healthcare system. And if everyone works together, I think everyone can win in this environment.
All right, thanks, Trent.
Yes, thanks. Thanks, Shara, for stealing my speech, my opening monologue. No, I think Shara said it really well. I think value-based care is and should be the future of the healthcare environment and the healthcare landscape that we push forward to really solve the challenges and truly the problems that all of us as individuals, all of us as employers or leaders within our employers, as well as just the nation and where we go from a healthcare perspective. Value-based care puts the impetus on all of us together and not one party or the other to really think about the accountability from a cost perspective and the outcomes that we're trying to drive. The Baylor Scott & White Quality Alliance is where I have served over the last 7 or 8 years. We live and breathe value-based care every day. The Quality Alliance manages about 800,000 members in different forms of value-based arrangements today, where we, the provider system, has some form of risk or some form of skin in the game as it relates to cost, as it relates to quality improvement and quality outcomes, and also the experience that our members and our patients and your team members go through the healthcare system. We created, as a provider, we have created a disastrous healthcare experience in many respects, and a confusing one and a complicated one that challenges everybody. And I think the focus on that experience side is very important to elicit and to drive engagement with individuals and with members to really take advantage of opportunities to get in front of their healthcare needs before they get to something that they may need. This is not a sick care business. It has been a sick care business, and we need to get out of the sick care business and truly into the health and well-being business. I think where value-based care starts for us, and as a large provider system, we have a lot of hospitals, a lot of big assets, a lot of physicians that work for us, work with us. We have to focus at the beginning, and we start with the primary care relationship. And as Shara mentioned, primary care is essential to managing the overall costs and the overall spend. There's plenty of statistics out there and plenty of studies that say while primary care, we pay primary care physicians 6 to 8% of the healthcare dollar, they influence between 60 and 80% of the healthcare dollar. And so how do we not necessarily right size the payments to primary care, but how do we emphasize the importance of that relationship and engagement with primary care? One of the innovative things that we've certainly seen over the last 5 years is the virtual services, virtual care, telehealth, video visits, et cetera. But all of you have been offering those with your employers, or you've had your employers give you an MD Live or a Teladoc or a Doc on Demand, and they've been there for 5 years, and no one uses it. No one, we see 1%, maybe 2% of utilization happening in a virtual or telehealth visit. When COVID happened, that changed fast. That changed across the country, and there were providers and plans and plan sponsors that were prepared for that. And then there were those that were not, that are struggling even today. And I think as we innovate and integrate virtual care and virtual services into our world, and into healthcare, it's important to recognize of what that does for the member and what type of experience that can generate for the member that they begin to think, well, now that this is a good experience, it does work for me, and I'm safe in my home. I can do many of the things. There's many new innovative medical groups like Crossover Health that are coming to the market where 70% of their services are offered virtually. 70% of the services and interactions they have with their members are offered virtually, and they're taking care of the members, and the experience is great. That as a provider system is our goal, to deliver services and experience that meets the individual's needs, that's at the lowest cost point and the lowest price point that we possibly can, but also that's looking at the patient holistically. The integrated networks, which is the Quality Alliance is a part of, we have hospitals and physicians and surgery centers and imaging centers and post-acute care facilities and pediatric providers all wrapped together, coordinating the care. It's not, as Shara mentioned, PPO environments are not environments to control costs. They never will be environments to control costs. They offer choice and they offer great access, but they will never be a cost mechanism to really manage our healthcare environment and our healthcare costs. And with an integrated network, whether that's with Baylor Scott and White Health or whether that's with others, you remove some of the duplication, you remove some of the inconsistencies of care that happen on a day-to-day basis. You have physicians talking to one another, not over a phone, but electronically. There's integrated network or integrated data solutions for the medical record, and we're able to have those conversations quickly, saves time, saves money, and also provides a member an experience. Is when I show up to an office, everything that's happened in my previous visits, that provider already knows about and is ready to really look at my care holistically. And that's really where we as a provider system have to move towards faster. We have to get to the place where primary care can quarterback the care. And we can do that in different models. We can do that in different solutions. As Shara mentioned, HMOs are not the HMOs of the 90s. We had no data back in the 90s to really understand how to manage healthcare. It was a payment model that didn't work. But the payment wasn't the problem. It was the overall wrapping around it and what that meant for the experience of the member. And so I think bringing those together, looking at network-driven solutions of where the providers of the network can be held accountable for costs. We're willing as a provider system to be accountable to you as an employer or to you as an individual for the cost of your healthcare. We take risk in environments. Risk is not a new thing, but it's certainly a new thing over the last 30 years. Where providers are assuming some of the risk. We're assuming the accountability of cost and quality in the experience. And we have to get to that place. As a provider system, I stand in front of my hospital presidents and talk about my goal is to reduce the number of times a patient comes to your building. And my hospital presidents are now incentivized to do just that. Their compensation is driven on value-based metrics. At Baylor Scott and White, we have integrated the value-based care mission and ambition across our organization. It's not just the Quality Alliance who sits over here in a corner. It's our entire organization, and many other provider systems are like that. So as Shara brought up quickly, the move to value-based care and what CMS has done from a value-based care standpoint, what the private market has done for value-based care, we have to double down in this environment and moving out of COVID, although we're still in COVID, but as we move through this journey of this global pandemic and costs for employers are so key and managing their business is so key right now. There's solutions that can help, and there's solutions that can not only save money. This is not just about saving dollars. It's really about getting in front of the problems that our populations and our communities face, and how do we drive to different solutions. And I think we have those in the market, and we have those in different environments across the country today.
Well, thank you both for those initial thoughts. Thank you for stealing all my thunder. So we have no more questions left. Now, let's get into our thoughts on COVID-19 and the pandemic. I mean, certainly, that's impacted everyone. I mean, how have you seen the initial changes to your organizations, to the healthcare delivery system, and what are the permanent future impacts that we're seeing? Okay.
Yeah, Rob, that's a great question. I think obviously coming out of the pandemic, the immediate changes was even a faster shift in the virtual services and how we can engage members safely from a distance when appropriate, but also when patients and members needed physical services, how do we do that in a safe environment? It's also improved our own internal work around, even if we weren't in a pandemic, we have learned things to keep people safer within the walls of a hospital or in the walls of a physician's office. But when it jumps to the first thing that pops out is certainly the virtual and telehealth resources. We, previously our provider network and our physicians that are part of Baylor Scott and White probably did 2% to 5% on any given month number of services were done virtually. In April, we were at 70% offering virtual services. Baylor Scott and White was in a strong position to shift and pivot that way quickly. We have built and invested heavily in MyBSW Health, which is a fantastic patient portal, member portal. It's an app. You can go to it on your desktop, and it has virtual services with a one-click button right there. Our providers are able to use that platform to engage their patients. But one of the other things that we did was really pivot on some of the electronic communications that may not be a face-to-face visit on a video, or it may not be a phone call, but just an asynchronous text message or an asynchronous chat-based questionnaire of how you were feeling. We quickly established a COVID e-visit screening. And so it was members were, people who use the app could download it and answer certain questions. And we did over 306,000 of those COVID specific e-visits dating back to March 12th. That's a lot of visits. Now, what that resulted in, and it was screening for those who were fearful if they had COVID or do they need to get tested for COVID. And what that resulted in is 70,000 COVID specific visits that followed that screening to say, here's a video visit with a provider. You triggered one of the screening checks, or you triggered one of the mechanisms that you would need further consultation with a provider. And so that was 70,000 video visits that resulted from those screenings. We've completed over 700,000 virtual visits within our clinics since March. A lot of those are established patient relationships and patients needing to manage their chronic conditions, and our providers were able to utilize the platform to engage them safely in their home. But over 700,000 of those video visits were completed. Another 150,000 phone visits were completed since March, really focused on the urgent care needs, the immediate acute needs that a member may have, and they're still hesitant to come back into the office. Even today, we still have those capabilities. Our hope and our challenge to our providers is, maybe we reach 70% of our visits were done virtually. We're not sustaining that today. It's probably around 20 to 25%, but that's still 20x what it was pre-COVID. And our challenge to our providers is we need to maintain that. Virtual services are cheaper than office visits. They're safer than office visits, even without a pandemic. And so our challenge and our focus is, how do we create solutions that can engage members where they are, in their home, at their office, reduce time away from work, reduce time away from their family. And we believe virtual is a huge element of that needs to stay. It's also impacting emergency room visits. We've seen a 50% reduction in emergency visits since March. That probably means 50% of our visits pre-March were unnecessary in the ER. And so we want to maintain that. We don't want to drive that back to the ER. We want to maintain those relationships and provide the community with more affordable alternatives to seek care when they need it.
Sure. Any thoughts from you on the whole concept of COVID-19 and impact at Blue Cross?
Yeah, I'll first say that I was one of those 700,000 visits y'all had, Trent, and it was a really good experience. It was quick, it was convenient, it was efficient, and it might not have been something I would have considered, but it was good. I liked it. So that's something that I think that we will see more of going forward. So kind of getting back to your original question, Rob, what's been the biggest impact? I mean, health insurance, this is all about predicting trends and looking at data and trying to figure out and forecast what will costs be. And obviously, when we did that in 2019, we had no idea that COVID-19 and a global pandemic was on the horizon. So we missed on our membership, we kind of missed on our trends, and now we're challenged. What's going to happen in 2021? Are we going to see more of the same? Are we going to see pent up demand. And so this whole predicting what's going to happen with health costs is kind of throwing us into a little bit of a tailspin. And for example, on the on the health exchanges, we have to file our pricing around May and do that prediction very early in the year. And so it's been really challenging this year. And as a matter of fact, we ended up providing many of our insured groups some financial relief because we didn't see as much elective services as we expected. And we just don't have that much data. We had a swine flu pandemic, which was very different back in 2009. We're 90 years old. We're not 102 years old. So we don't have any data from the Spanish flu back in 1918. And so managing those unexpected trends has been really our biggest challenge. But like Trent said, some of the silver linings that I think have come out is telehealth. I mean, if I look at our data around January and February, we were seeing about 17,000 telehealth visits in a month. Second week in April, it spiked to almost 250,000 telehealth visits, and then it's down to roughly 200,000 now. So the adoption is much bigger than it was before the pandemic, and I think we're going to see it continue as providers have built the ability and have enabled telehealth, like Trent described, and patients are seeing that it is convenient and they like it. Now, of the telehealth visits we've seen, most have been with the patient's normal provider. So while we offer some of those vendor services like MD Live, that's not been the majority of the visits. People are going to their normal healthcare provider for the telehealth visits. And also we've seen it, behavioral health, mental health services can be very effectively delivered through telehealth. We have a shortage of providers, especially in certain geographic areas. And I think we're going to see increases in mental health diagnoses. And so I think that is creating an access point that maybe we might not have considered before.
Okay. Well, regarding the ER visits, what about the data that shows that, people are basically ignoring at times serious health issues because they fear for their own personal visits? What do you estimate the impact this is as far as patients and future costs?
Yeah, it's a great question, Rob, and I think Abby, thanks for sending that in. I think when we look at our data, and especially around our clinical quality metrics and specifically around preventative screenings and preventative services, we saw within the first 3 to 4 months of COVID, we saw a significant dip in those services and those scheduled and needed screenings of about 18%. We saw breast cancer screening drop by about 17%. We saw colorectal cancer screening drop even a little bit more than that. And so certainly that has been a heavy focus at the Quality Alliance. Our job, we have a team that is heavily focused on looking within the data. We look in the medical record as well with our partners, the payers and different employers. We get claims data, so we mirror those together. And we are heavily focused now as we come through this period and while things aren't open back up completely and there's still some hesitancy, but we're actively outreaching those members at what we call Gaps in Care team. Our Gaps in Care team is connecting with those members who should have had their breast cancer screening or who should have had their colorectal cancer or who are due an A1C test if they're diabetic or need to make sure we're tracking their hypertension metrics. And so we're engaging those. Not many of those screenings cannot happen virtually. And so we ensure, and we've provided different safe care resources. Baylor Scott and White launched our Safe Care program to really ensure the safety of our members. And there's parking lot check-ins and you're escorted straight back to your room without very limited interaction of those, temperature checks and the screening checks at all of our sites, just to ensure safety of our members. The transmission of COVID is within our own staff and our own employees within our facilities is incredibly low because of the rigor that we have taken. We have seen very limited transmission when a COVID positive patient comes in contact with one of our staff members, and it's because of the safe work programs that we have put in place. And so we explain that to members. We're engaging them at a different level. We're representing the providers. We're representing their primary care physician. And so they see us as that part of that overall care team. And so they have that trust in their provider and we can facilitate that as well. So we spend more time on that. We spend more time engaging. This is how we will do it safely. This is how we will get you in. But we also explain some of the catastrophic events that can take place if we don't get these things done and the importance of them. And so we start to see those come back up. We start to see those metrics and those screening services have increased. We're not back to where we need to be. We're not back to where pre-COVID levels, which even pre-COVID levels weren't to where we were striving for. But we've certainly seen an uptick in that. And it's really going to take engagement by the provider systems. It's going to take engagement at an individual level and the accountability level at an individual. And it's going to take partnerships with employers and payers to come together and say, hey, here's things we can do to help you do this safely. These are the important aspects and the important reasons why you do this. So many times we tell people to do things, but we don't give them the reasons. We don't explain why, and we don't educate them. And so part of our Safe Care program and our GAPS care team really does focus on a lot of that education of what's the value, what's the importance of why these things are important for your overall health.
Sure, Shannon
Thanks.
had a question with respect to the fact that Blue Cross announced that they were going to pay televisits permanently for federal employees, and she wanted to know if this was going to continue for all Blue Cross Blue Shield members.
Yeah, I think we're now still in the epidemic, the COVID-19 crisis period, and that's been announced through the end of the year. We changed many of our telehealth policies. We paid parity for telehealth as if for E&M visits as if they would have been done in the physician's office. I think you're going to see that continued after the first of the year. So we're definitely changing many of our policies to encourage and continue paying for telemedicine after the first of the year. We're continually just evaluating what makes sense. But I would refer you to our website, Shannon, and we're announcing whatever we're continuing after the first of the year, the latest on that website. But yeah, we'll see definitely enabling and policies that do pay for telehealth and telemedicine.
All right, Trent, you all recently had a big announcement. Can you share with us more about your partnership with Catalyst and why that's going to be a good thing for employers and consumers?
Absolutely. I think first and foremost, the Baylor Scott & White Quality Alliance and Baylor Scott & White Health, as well as Catalyst, is their mission is to support the communities and continue to improve healthcare for our members. And we both strongly believe that value-based care is the future in order for us to do that. And so I think there was strong alignment in vision, strong alignment in our focus for our communities. And it was a great fit. Catalyst has done some amazing things. They have pulled together a large number of primary care physicians that are independent. They're independent practices. They're independently owned. They've aggregated together and worked together on a lot of initiatives and innovative solutions. I think what the relationship gives us the opportunity is to really bring to the market different solutions that offer a broader network of primary care. It is an investment in primary care. Baylor Scott & White employs and has a medical group that is heavily primary care. We have other independent relationships and other health system relationships that we work with at Baylor Scott & White. And Catalyst is another one that's incredibly valuable to the community and incredibly valuable to delivering value-based care to the market. So we're excited about that. It's in the early goings. We just got to work together to really develop solutions that we can bring to the market, that we can put in front of employers and individuals to say, hey, these are new solutions that we think can support you from a healthcare need. It's also about supporting the primary care provider. It's also about changing the way we fund and pay for primary care. Prospective payment for primary care is important, and we need to get there for primary care. Fee-for-service does not allow a primary care physician to innovate his practice. He's driven based off utilization. He doesn't incentivize a primary care independent practice to hire a pharmacist or to hire a care manager or a social worker to be part of his care team, because there's no mechanism in fee-for-service to pay for those things. And so in prospective payments, broadening that care team, taking a more holistic view, and Baylor Scott & White and Catalyst both strongly believe in that, and we'll be able to bring that forward to support not only our patients and our members in the community, but also to support and grow the influence of primary care in the market. So we're super excited. Dr. Crow and his team are fantastic leaders. They're fantastic individuals, first and foremost. They have a passion for their communities. They have a passion to serve the community in a better way from a primary care standpoint. And we at Baylor Scott & White echo that and match those visions heavily. So we believe it's a great partnership, and we're super excited what that's going to bring to the market.
Okay. All right. And Shara, while we're on this concept of new partnerships and announcements, what about the Sanitas? I mean, that initiative, is that a part of a larger vertical integration strategy, and how's that working for Blue Cross?
I don't know that I would describe it as part of a vertical integration strategy. I think it's something that we entered into. Any Blue Cross member can go to a Sanitas Health Center, and that's all of our products, whether it be products that we offer to employers or individuals on exchanges or Medicare Advantage products. But this was specifically designed to serve individuals that are getting their health care on the public exchanges. And these are individuals who might be eligible, lower income, eligible for premium subsidies on the health exchange. And we rolled out a new product this year in 2020. It's called My Blue Health. It's available in Dallas County and in Harris County. And this is a Sanitas Health Centers. They offer services 7 a.m. to 7 p.m. They offer bilingual services. Not only can you access Sanitas Health Centers for primary care, you can go for urgent care. And many of them also have Blue Cross Blue Shield customer service representatives co-located with them. Now, we went into this in the major metro areas of Houston and Dallas in 2020. This is not a great year to measure success of these health centers. So as we move into 2021, we're hopeful that we'll see more volume. And I think that this provider has worked with Blue Cross Blue Shield of Florida. It's worked with other Blues plans and has been very successful, especially in serving this public exchange population. And I think we're going to have to see how it goes in 2021. We enjoy the partnership. We're hopeful that we can expand it, but right now we're focused on Dallas and Houston and making those successful.
All right, thank you. Okay, one of the questions that comes up a lot is the concept of financial transparency. I can tell you in my world, it comes up a great deal when you're talking about employers and the cost of healthcare, and consumers trying to determine, what is the true cost of care. What do you see? Where do you see this currently, and where do you see it going in the future?
So, I'm happy to take that one. Financial transparency around the cost. I'm going to interpret that as financial transparency around the cost of care. In Medicare and Medicaid, you have these standard fee schedules. There's not a whole lot of variation in unit cost of care, but in the private insurance world, there's a lot of variation in the cost of care. Accessing an MRI might cost $600 at one place and $3,000 at another place. And so we want to enable our members to shop for care and understand prices. So there are probably about 1,000 common conditions where we make those prices available on our website to our members. And when you access care, you not only, you got your hospital bill, you got your physician bill. If you're getting surgery, you get your surgery, you're getting your anesthesiology bill. You might have a pathology bill. All of these bundled in. So we try to include all of these costs on average by provider to our members so that our members can shop for care. Unfortunately, we don't have that many clicks. We don't have that many members who are going out there. We want to make that information available because in all of our decisions that we make, we consider price when we buy food, when we buy homes, when we buy cars, when we make all these decisions. It doesn't mean we always choose the lowest cost, but it is a factor in the decision. And we think it's important for our members and frankly, many of the ACO and provider groups that we work with to better understand those healthcare costs. And that helps them manage the overall healthcare dollar. So we think member transparency is very important for members to consider the cost as they shop or as they make choices for their care.
And I think we at Baylor Scott and White agree completely. I think pricing transparency is important. I think unfortunately, the complexities of the financial model of healthcare makes it even posting prices on the website like Baylor Scott and White does. It makes it difficult for a consumer to understand what that means. If you got to put in this DRG code or this CPT code or this code to understand what it's going to pay. I think one of the things this current administration has done has been pushing transparency pretty heavily. And one of the regulations that's come out that'll be effective in January is healthcare systems and providers are going to be required to post. There's 300 shoppable services, and it's things Shara mentioned, like MRIs, a colonoscopy, some basic services that it does make sense, and it is a more price sensitive decision. And it's going to be a requirement for providers to post that very clearly in a tool that members can easily understand based on their plan and their insurance and those different components. And so we support that, and we will be ready to do so in January to follow the regulations, but also believe we've got to make it even easier. And so we're exploring today ways of how we can take, once we have a member through our health plan or through the Quality Alliance or through a payer partnership that we have, and they're using the MyBSW Health app, we want to put pricing transparency within the app. And so when they go search for an orthopedic surgeon and they type in, I need a knee, I have an ACL tear, or I have an ankle problem, and it shows them their surgeon. We want to put that pricing transparency of the services that they may be able to receive within our app to make that simple. So I think the consumer pricing transparency is very important. I would say as a provider system, the other thing that's very important to managing cost is making pricing transparency to our physicians and to our providers when they're making the decisions at the bedside for a referral, or when they're making the decision for prescribing this drug. We've seen and presented plenty of data to our physicians and holding them accountable to prescriptions and drugs that they're prescribing that are thousands and thousands of dollars, and they had no clue. Oh, well, I can easily prescribe something different that'll get the same effect that's a tenth of the cost. And so I think making it aware and that's part of what the clinically integrated network and at the Quality Alliance that we do. We have a dashboard that shows our physicians those types of things. Shows them the cost of their drugs that they're prescribing. We show them the overall cost of their certain services and certain providers that they're referring to. And so also the amount of utilization that's happening and where they're taking their members for care. So I think it has to come together if we're going to. I don't think an individual is going to be able to understand if I go to the hospital for pneumonia and it's with complications and I end up getting this extra resource, or I have to have this procedure, taking that in to understand the facility cost, the physician's fees that they took care of you, or the surgeon and the anesthesiologist. That is a complex world that unfortunately we have created that I think we're taking steps to improve. But I think the transparency on both sides of a consumer standpoint as well as the provider standpoint is very important.
Well, I mean, there's really no uniformity with respect to the cost of healthcare. And, when do you see commercial entertaining similar, plans to MSSP type Medicare contracts? Is that possible?
Well, I think that's kind of what we're trying to move toward in payment reform and in value-based care. And programs like that are very difficult to operate in a broad access, open access PPO, especially with a high deductible. And so I think that was kind of my report, my point around the plan sponsors. If they buy into this value-based care notion and want to be a part of it and want to enable it, I think it's important that they think about their benefit designs and consider benefit designs that do enable value-based care so that we can pay and improve and pay providers differently, incentivize them allow them to establish that relationship with a primary care physician. So benefit designs that require a primary care physician selection, that are kind of HMO based, to where they allow different types of reimbursement structures other than fee for service, and also have the right kind of benefit design. So high deductible plans are incompatible with paying capitation or paying differently. How's a primary care physician that's getting a standard payment for that member going to know where that member is on their high deductible plan? That's one of the data challenges that's very difficult, and why we need the plan sponsors to kind of get on board and help in designing benefit plans that enable value-based care.
Great, thank you. Thank you. Trent, do you have anything to add?
No, nothing significant. I think Shara's right. I think there's opportunities in how we design products and solutions in the market, and then in how we design the payment system around that. I think there's opportunities as we have taken in risk-based agreements, where we basically are guaranteeing certain overall costs for a population. And we're saying that you're not going to have a cost greater than this, or we're going to be on the hook for some of that cost. I think we've demonstrated in our Medicare programs the success that Baylor Scott & White has had in managing in a large Medicare population, and managing from a value-based care perspective, reducing the cost, and how we compare in the market. So no, I think there's value-based care is an answer to that, and it's going to shift where it is a much more, maybe it's a much more fixed reimbursement mechanism, or it's a Medicare-based reimbursement. Those different components are interesting, and going through those different changes in the models are important, but ultimately the total cost of care is what matters. It's not necessarily the unit price, although unit cost can be important, but that's not what drives our healthcare costs and the healthcare challenges we face today. It's overutilization, it's underutilization that high deductible plans sometimes can create. And I'll just put that off because I don't want to use my dollars. I'll save that for catastrophic purposes. And so those are the things. And how do you engage a member and have them take some skin in the game for the accountability of their health? Our health decisions is what we need to be talking about, and how do we build up our health and increase our health and immunity and different things, and not worrying about sick care. Worrying about how we pay for a hospital visit is worrying about sick care, and we have to get in front of that if we're going to truly transform healthcare in this country.
All right, thank you. Over the past several years, we've seen a great deal of aggregating of groups and consolidation in the healthcare community. What do you see as the long-term effects of this activity, and how does it affect the sole practitioner?
Yeah,
Go ahead, Trent. I'll chime in after you do.
Yeah, I think it's a great question, and a challenge that individual private practitioners face with the economics. And I think that's where the value of clinically integrated networks, because we have over 4,000 independent private practitioner physicians that have joined the Quality Alliance that we help support. We help give data, we help them perform, we get them in value-based models where there's financial reward if they perform strong. And so I think in environments like that, the private practitioner can absolutely thrive. I think Catalyst has done a fantastic job in supporting the private practitioner and the independent physician model, and ensuring they have that semblance of independence, and they can drive and do their care model, but with some accountability on top, and some accountability on some very core specific components of what healthcare should be and how healthcare delivery should be done. So I think in the future, it's from our standpoint, at least from my standpoint at Baylor Scott & White Health, it's partnership opportunities. There's relationships that can be developed. I don't view this as a our goal is not to consolidate private practitioners in the market. It's to partner with them, to support them as an independent practitioner, and to support the needs that them and their families and their own colleagues may have. And I think that's what's important. I think the Catalyst relationship that Baylor Scott & White now has speaks loudly to that, of how we support that model and want to continue to do so.
Yeah, so let me take that. I think I heard aggregation, and I think maybe I heard consolidation. So I'm going to separate aggregation from consolidation. So aggregation, I'm going to consider the types of things that Baylor Scott and White is doing with Catalyst. This is allowing physicians to collaborate. We talk about population health. You have to have a population to do population health, and a lot of these independent physicians just don't have enough of a panel to have a statistically valid sample to do population health. So aggregating is important. Sharing data is important. Most of our accountable care organizations are actually with independent physicians. Some are with large integrated systems, but most are with independent physicians. And we actually have a joint venture with the Texas Medical Association called TMA Practice Edge that helps independent physicians participate in value-based care without having to be acquired or participating in a large system. So we think data aggregation is important. We like that because it enables population health. On the other side, you have consolidation. That's mergers and acquisitions. And we've seen a lot of hospital consolidation in Texas. It generally results in higher prices. In hospital, we think hospital competition improves the quality of care. We have a particular concern. There are 2 communities in Texas that were 2 hospital towns that are becoming 1 hospital towns. This is Abilene and San Angelo. So we're very concerned about the impact of no competition and prices in those communities. So pro aggregation, concern about consolidation, if that helps answer your question.
All right, that's great. That's great. All right, let's transition to the question on standalone ER facilities. You know, they've been popping up for some time now, and it's been very disruptive to our payer community, our provider community, and to consumers. What's been done to address this challenge?
Do you want me to take that, Trent?
You can take it first. I can certainly respond.
All right.
We certainly have some, but you probably deal with it more than I can provide.
Yeah, I mean, this is not a phenomenon that happens in many other states. Texas is very unique in that it has these freestanding emergency rooms, and it's because of a policy. It's because freestanding emergency rooms began licensing around 2009, I believe. And some protections in policy kind of encouraged some policies that were intended to protect consumers in a true emergency have enabled and encouraged many of these freestanding emergencies to not participate in health plan network. So policy created the problem. We think that policy can help with the problem. And that's why we've been very proactive in the Texas legislature to prohibit and curb poor marketplace behavior that we consider by a lot of these freestanding emergency rooms. We see a lot of price gouging. We see particularly price gouging with a lot of these COVID-19 tests. I think you've read in the paper about the doctor who worked at a freestanding ER who got an $11,000 bill for his COVID-19 test. And so transparency rules that have been enacted in the Texas legislature that require the freestanding emergency rooms to disclose whether they actually participate in plans. You saw many of them saying, hey, we accept all insurance plans. It didn't mean that they had a contract with the plan. I think you'll continue to see changes in the Texas legislature that help members and patients understand that they could potentially get a very high bill, they could get a balanced bill, and knowing the difference between providers that are in the network of their insurance carrier and that are out of the network of their insurance carrier.
I think in Baylor Scott and White, I think we have 8 freestanding emergency room facilities. All of those facilities are in network with all major payers. They're in network with Blue Cross, United, Cigna, all of them are. Baylor Scott and White does not support an out-of-network strategy within our walls and within our facilities. At the Quality Alliance, we even double down on that. And when we see within the data that a out-of-network physician, an anesthesiologist or a radiologist or an assistant surgeon, we attack that and we work with our physicians and let them know that's not acceptable. We do not strive for an out-of-network strategy. We work and try to partner with our payer partners as well as our provider partners to bring and get an in-network strategy. We've worked hard over the years to ensure that doesn't happen. And when we have a value-based agreement or a network-driven solution, we ensure that those don't occur, that balanced billing does not happen. We don't support that. I think some of the legislation that's come up recently in the country, as well as in the state of Texas, have supported individuals in that environment and provided at least some avenue to remove some of the challenges financially that those create. But Baylor Scott & White fully supports a network strategy and not an out-of-network model. That is not something we support for sure.
And Trent, thank you for distinguishing between the freestanding emergency rooms whose business model is out of network as opposed to those that are in the network and typically associated or owned by a larger system.
All right, let me go to a question here that consumers are notoriously unengaged in their own healthcare. You know, how does value-based systems basically engage these consumers, and what role does consumer behavior play in their own healthcare outcomes? And what are your organizations doing to promote healthy behaviors?
I'm going to jump in before Shara, because this is always
That's all right. Go for it.
my favorite topics. I think it's incredibly important to engage the consumer, engage our members and patients directly. And I think the relationship with the provider is the most trusted relationship. And we have put resources around our physicians that solely focus on engagement. We have built patient advocacy programs and patient advocacy models that are truly there to navigate a member throughout their healthcare journey, whether it's just finding a provider or whether it's a very complex need. We have nurse care managers, we have social workers, we have pharmacists and pharm techs and different resources that we have wrapped around the physician. Shara will agree with me, care management and disease management resources happening on behalf of the provider are far more effective than they're happening on behalf of a payer or a third-party vendor. The data proves it. It's true. I trust the relationship with my provider versus maybe coming from an outside party. And we've been able to see stronger engagement. And so the great thing about the relationship with Blue Cross and other payers is they understand that. They support us in that. The value-based models fund some of that for us. We create engagement models around that to really support that. And when there's that direct relationship with a provider or with a provider system, we just see those higher engagement models. And so the other exciting thing is when we as a provider system are working directly with an employer, we have the opportunity to learn how to communicate with your members. How do we, you as an employer, you know your people probably better than most and know how they like to be communicated. What are the words that trigger and what are the things that need to be said to get them engaged? And so we partner closely with our employer partners to really elicit that engagement. I think to me, the patient advocacy and navigation and engagement models and resources are probably one of the most important resources right now coming out of COVID and to usher in value-based care, to engage those members where they are, understand what their resource needs are, understand how they need to be served or how they want to be served is incredibly important and invaluable. There's a reason companies like Accolade have skyrocketed across the country in value and what they've done from a financial standpoint. It's because we need those resources. And at Baylor Scott & White, we've invested heavily in that. We've invested it virtually. So we put those resources virtually to make it easier for those who want that. We also have invested it on the analog side and the phone call side and the triage lines and those types of things. So I think it's an important aspect. And I think when the provider system is willing to put the investment into engage members at that level, and it's not just sick care anymore, now it becomes proactive healthcare management and well-being management. And that's what we need and that's what we have to have. We believe strongly in that and invested heavily in that type of model.
Okay. Well, thank you, Trent. Thank you, Shara. At this time, we're going to conclude our panel discussion. Thank you for your great insight. And at this point in time, we're going to turn it over to Kenya.
Thank you all for such a great conversation. As some have noted, healthcare is hard. And I appreciate that we have people like you doing the hard work to make both the delivery and payment for healthcare as it continues to change. And this really, we'll say we live in interesting times. So I appreciate that all the work that you're doing and that we as consumers, payers, providers, plan sponsors, and patients, right, that we all have to continue to work together. And I really appreciate your insights today. We are going to continue to chat a bit for those of you who can stay on. And Ken, I'll turn it back over to you.
Thank you very much. And just to remind everybody, Kenya Woodruff is the current chair of the Health Industry Council Foundation Board and our partner in this event today. And we can't thank you all enough for, it was actually Kenya and Ben Isger and Pat Driscoll's idea for this collaboration. And as Stephen mentioned earlier on, we intend to do this at least quarterly on a go-forward basis. And I just think it's also important to note that we're in the throes of finalizing our planning for our annual healthcare conference, which is always one of our biggest events of the year. It's scheduled for January 22nd, and it will, right now, we have a tentative hold on our traditional host facility, Texas Scottish Rite Hospital, but of course, that's very tentative, and in fact, they're not even open right now for any external meetings like this. But we do have a tentative hold on that. If not, we will obviously convert to a virtual program, much like today's program, but probably on a different technology platform because of the size of the audience. So in any event, we thank you all very much. Kenya, Stephen, thank you for your leadership in this program. Shara, and Trent, thank you for the great content today. And Mr. Causey, thank you for moderating a very insightful and engaging dialogue today. So thank you all very much. This meeting is adjourned, but please feel free to stay on and engage in a little bit of networking time. I think Jeffrey is going to leave the line open for probably the next 20 or 30 minutes. So thanks again for everyone being here today.
Thanks for having us, Ken, and the team, and thank you all for joining in a great discussion. Thank you, Sharon.
So there were several other questions that were in the chat, and I don't know, Trent or Shara, if you noticed those during the call, but
Yeah,
there were
let me
several
scroll
others
down.
that we didn't get to, but nevertheless, they might be worth taking a quick look at right now.
All right, so I think we touched on the engagement, and I think Trent covered that really well. I think he's suggesting that maybe if someone gets a phone call and their caller ID has their primary care physician, they're more likely to pick up. And, I maybe if it says health insurance company, they're less likely to pick up. But I agree, and we try to enable that that engagement with the providers and one of those things is letting those providers, the primary care providers, know what else we know about those members or those patients that they might not know. A Baylor Quality Alliance physician may or may not know if their patient went to an emergency room outside of their system. We can give them claims data so that they can outreach. They may or may not know before they saw them that they had a chronic disease that we were aware of from past claims experience that they are not, that they didn't know. We can do some predictive modeling that we can share on patient risk factors so that they can close gaps in care. So I think that's the type of collaboration where we, through our claims data and the information we can collect, can help fill those gaps with the primary care physician so that they can decide, if they've got a panel of 100,000 patients, they're not going to reach out to all of them, but they can help focus on the ones that really need that outreach and need that engagement. So that's an example of the things that we do. Challenges around... Go ahead.
No, I'll say that is a great, and Preston had asked a question around that data sharing between providers and payers, and that's incredibly important. It's integral to being successful in value-based care. I go back to, I think I said it in the 90s, that was a huge reason of why the HMO models failed, because there wasn't that data. I think the challenges is, I think Preston, your question was, the challenges of the sharing of the data is one, there's so many disparate systems. Every payer has a different claim system. Every provider many providers have different EMR systems. There's certainly some that share those, and those are great experiences when you have like medical records. But even within the Quality Alliance, we have, physicians who there's probably 50 different medical records across our network. And that becomes a challenge that's difficult. We've created things at the provider level to try to mitigate some of that. But I'll say that is certainly one of the best elements of value-based care, and ours at Baylor Scott & White's relationship with our payer partners like Blue Cross of that data sharing, and we make sure it's protected. We have rules of how we use it, and we certainly want to protect privacy of our patients and our members, and even some of the information that's there is not shared outside. But I think that's the beauty of the value-based care models. If you're just in a fee-for-service PPO environment, like Shara said, you have no idea what's happening around you when your patient is not in front of you. And so that connection and that partnership to share that is invaluable to the success that we've had so far.
Right.
Yeah, and I think another challenge is, we could dump all this claim data, but it's really pinpointing and using analytics to say, here's how you could practice differently. Here's this specialist that you're referring to that is overutilizing, or here's this hospital that you're referring to that's more expensive and you could go to a more affordable. So it's kind of finding those opportunities that are unique to each physician group that help them practice better and be more successful in these models that actually incentivize more cost-effective care.
That's great. That's great. Hey, both of you, Paula has a really good question that she's posed. So Paula, do you want to jump in? Paula Schofield, you want to ask your question?
Sure. And it was to Shara. Hi, Shara.
Hey, Paul and I go way back.
Yeah, we go way back. Warren Buffett bought the Ebby Halliday companies recently, but prior to that, independent contractors, we have been paying unbelievably large amounts of monthly. I wish I could have saved all that money in the past. And as groups, he was able to offer the company insurance, which has been fabulous, especially for my daughter. However, I'm just curious about the independent contractor groups. Why is it we don't get an opportunity for group insurance? I mean, I just have always wondered that question. Never asked you that personally, but thought I'd ask it now.
Yeah, so if you look, all right, so it really has to do with, I'm going to introduce a concept called adverse selection, and that's an insurance concept. And so if you've got a whole group of people that kind of have a stable, a lot of healthy people, some sick people, you can rate them as a whole group and really predict what's going to happen with that group, then you average the cost of all those individuals. Now, when you say independent contractor, that means that you're buying your insurance for yourself and your family.
Right.
Okay.
Right.
All right. A lot of that changed with the Affordable Care Act, where a lot of the standard essential benefits that maybe were not offered in other plans had to be added. You had community rating. And so the way the pricing was done actually drove up a lot of costs for small businesses and for individuals. Now, some individuals get subsidies to pay for that based on their income level, but a lot of people do not. And so we saw a lot of huge increases in individual coverage. Now, when you say pool together, how do you pool together as an association? So that's kind of like association health plans. It's not quite like a group, because some individuals that might be able to buy. So if I'm an association health plan, I'm going to make a choice. I can go in with the real estate association and check a price, or I can go buy coverage elsewhere. Well, if it's less expensive elsewhere and you're a healthy person, you're going to go elsewhere. And so that could potentially leave a pool in the association of only people who don't have other more affordable options. That was kind of complicated insurance stuff, and that may or may not have made sense to you. But that I think that just if you think about, we think about it as like risk pools of groups or risk pools.
Okay, thank you.
Shara and Trent, did you all see that one question? I'm trying to find it here from Roshni Shah.
Yes. I think that my best way to answer Roshni's question is prospective payment, and where driving fee for service from virtual visits to in-person visits and the difference in reimbursement we should be working on prospective payment models for primary care, and the direct primary care models, which Baylor Scott and White offers. It does just that. It's a prospective payment model for primary care services, and it doesn't matter what type of service you do. I don't want to disincentivize a provider to use virtual care because it's a better solution for certain things, and I don't want to disincentivize them to use a nurse or a care manager or a social worker to provide care when they can expand the resources and again decrease the overall total cost. And so my answer is definitely the prospective payment model is the answer to that question.
Yeah, I agree with Trent. I think she asked specifically about fee for service. And I think that right now we have parity between office visits and telemedicine. I see that continuing into the first of the year, but I think we're also going to have to keep an eye on what happens with the marketplace, what happens with the competition, what does Medicare and Medicaid do, and if we see abuses in telehealth. I mean, we see a lot of telehealth claims that are at the highest acuity level, and it's like, come on. Is this really at the highest acuity level if it's telehealth? So I think we see a little bit of upcoding. So we've got to manage and make sure that there isn't waste and abuse, and even, so far as the F word, fraud. But we also want to make sure we got to balance that with access. So I think we'll enter 2021 with that payment parity, but we're going to continue to monitor it with the market. Roshni also had a question about social determinants of health. There are a lot of things that we're doing around social determinants of health, but we're mostly investing with community partners. So not-for-profits that address things like health and wellness or chronic kidney disease or COPD. And so we directed many of our investments over the past several years in chronic kidney disease related to diabetes and COPD. And we've actually seen some improvements in prevalence of these conditions and the cost of these conditions in the communities where we have had interventions. And I have a kind of cool story of another thing that we did. We entered into this collaboration with Texas A&M, my favorite school, but they also are expert in rural health. So we have a $10 million collaboration that we entered into, I think it was in 2018 with Texas A&M, and they're doing these different interventions in rural Texas. 4 of them, I think they're going to add a 5th project, but one of them is in Milam County, Texas, where their hospital closed down. So I actually took a field trip last Thursday to see this virtual medical clinic that it's almost like a vending machine. It's located in the sheriff's office in Cameron County. It's about an 8x5 exam room. And you actually go in, you pay $65, you go in, and it is enabled. It's got a scale, it's got a blood pressure cuff. It has a huge screen where you actually interact with your nurse practitioner or physician or medical tech. You've got a stethoscope and a high definition camera that come from the ceiling that you can, put in show your throat or your ear or skin or whatever, so that the doctor, the healthcare provider can examine you. It's got an infrared screen that takes your temperature and also can show if you have infections, and it was cool. And then they have, almost like a vending machine, 200 of the most commonly prescribed medications that they can just dispense right there.
Wow, that's incredible. That's just incredible. Wow.
And they're also working on like a volunteer program with first responders. So they have about 30 volunteers who are tracked on an app. And if you have someone with an emergency, that volunteer first responder who has been trained can kind of help until an ambulance or other help arrives.
Yeah, amazing. I can see that Baylor Scott and White is going to probably implement that here soon. So the same program. So in any event, that's great.